Hi, I'm Dr. Ray, and I'm here to talk to you today about development of the vertebral column. I started the vertebral column in my weeks 3 through 7. We talked about paraxial mesoderm, and so if you didn't, if you need to really start from the very beginning, you might want to watch how the embryo turns into a trilaminar disc and then folds. So when we talked about paraxial mesoderm, this is actually one of the slides from that talk. We talked about how the mesoderm on the lateral sides of the developing notochord is going to divide into 3 sections. The most medial section was called paraxial mesoderm. And I said that that was going to give rise to the axial skeleton and associated musculature dermis of the skin. So that's what we're going to talk about today. There was an intermediate mesoderm and then lateral mesoderm that was further out from that. And so then I also gave you this slide, and I showed you sort of the big picture item, how these blocks of mesoderm, specifically paraxial mesoderm, were going to develop into special cuboidal shaped structures that we call somites. And then I showed you this slide. This is the developing embryo, and the most prominent feature, I think, is are the neural tube, and then also the somites that are running down the dorsal side. And I talked to you about how the somites increased in number until they further differentiated. Now we're going to pick up on that differentiation. So the big picture concerning paraxial mesoderm, this is the drawing that you have in your book. You can see in the drawing where the neural tube is depicted here, and you can also see the notochord depicted there. And this is sort of a little bit more, I mean, still a cartoon, but it's a little more of a realistic view where you can see the neural tube and the notochord. And this area here is the area that we're talking about where the paraxial mesoderm is located at. And I just wanted to orient you because this embryo is already folded, and so it's not anymore, it's not a plate. So we're already seeing it folding. We're already looking at interembryonic coelom that they're depicting in this cartoon drawing. So this is the area I want to focus in on right now. So that paraxial mesoderm is going to divide into 2 parts. The highlighted part is the ventral medial. So anatomically speaking, it's ventral and medial. And we're going to refer to that part as the sclerotome. And it's going to form the vertebra, and it's going to form the ribs. So we have the developing neural tube here, and then this is going to be the block of tissue that is going to divide into the vertebra. And then the rest of the paraxial mesoderm is going to be referred to as the dermomyotome, and that is more dorsal and lateral to the sclerotome. So the dermomyotome is going to form myoblasts, and actually this region here is the part that the myoblasts are going to develop from. The rest of it, this area here, is where the dermis the dermatome region is going to form the dermis, and that's going to make fibroblasts, which are going to make connective tissue. And so this part I'm not going to cover because it's covered when you talk about further development of the limbs and other things, and so another professor is going to carry up with that material. Okay, so what happens to the sclerotome? Now I'm going to switch views. So I just got you comfortable with this view, and I showed you where this was located at, and I needed you to hold that into your minds because now we're going to cut this embryo right here, and I'm going to switch to a frontal plane so that you can see how this sclerotome further develops, because it doesn't happen in this view. It really only becomes apparent if you look at the embryo in a frontal view. In your textbook, this is what they show as the same thing that I'm going to talk to you about right this second, but I'm just going to use this schematic here because it looks a little bit more realistic, and it kind of shows you more things like cells, and so I want to kind of give you this big picture. In both of these schematics, though, this yellow, wow, my color is off. This dark pink color is the notochord, and in the schematic it's green. So that's the developing notochord, and here's the mesoderm on the side of the notochord. That is the paraxial mesoderm. Here you have the dermomyotome, and this area is the sclerotome. So this highlighted area is the one that we're going to talk about. The sclerotome is going to condense into two different regions. Okay, so this is time, this is less development, this is going to be further along in development. So this sclerotome is going to go further divide into two regions. One is going to be a more loosely organized region, that's depicted here in this reddish pink color, and the green area is representing a region of the sclerotome that has more densely packed cells. Okay? Other things depicted in this schematic that you might want to pay attention to is the fact that we have nerves. I don't know why they made the nerve blue, but this is supposed to be a nerve, so it has a relationship to this developing sclerotome and also vessels. They specifically showed you here an artery. Okay? And so it has relationship to these nerves and vessels. Now I'm going to switch slides, and this is where we're starting at here. And I kind of just want you to follow the bouncing ball here. So the densely packed region of one sclerotome is going to come together with the loosely packed region of the caudal sclerotome, and it's going to form a vertebral body. And so if you look at what happens, these two regions are going to form eventually a vertebral body. So what I'm trying to point out here is that one sclerotome here with a loosely and a densely does not make a vertebral body, but it actually is only half of it is contributing, part of it is contributing to a vertebral body, but it comes together with the one that's caudal or the one that is above, depending on which one you're talking about, to form a vertebral body. So this is time, represented in time. This is less differentiated. This is further along the way. So you can, and we can reiterate that if you want to try to follow the bouncing ball here, if you just pay attention to where the artery is located. So here you can see the artery that is between these two sclerotomes, and the artery ends up being at the midline of where the vertebral body develops. So it's kind of neat when you look at the pattern, how the end pattern of the vertebral column develops, and also its relationship with the nerves are also held because the nerves end up being at the level of the intervertebral discs. So that's how this all comes together. Okay, and so if you want to follow the bouncing ball, when you're looking at schematics, follow the artery. And there's the nerve. All right, and so I just color coordinated this slide for you if you have my PowerPoint and you wanted to follow along things, but this is the YouTube movie, so you don't. All right, so what happens to the notochord? So this is time. I sort of brought this and sort of brought it up a little bit closer so you can see, follow with the notochord. The areas that are going to be the areas that develop into the vertebral bodies are going to be the areas where the notochord is going to degenerate. Okay, so you're not going to have the notochord remain in those areas or contribute to the vertebral bodies because the mesoderm from the sclerotome did that. But in the area where the intervertebral disc is located at, the notochord there is going to persist, and it's going to make the nucleus pulposus of the intervertebral disc. Okay, and that's what's depicted here. This is the intervertebral disc. The nucleus pulposus is the central region or central portion of it. The outer portion, the annulus fibrosus, is going to be depicted here in purple, and that is going to come from surrounding mesenchyme that's mesodermally derived, that's around the notochord, not from the notochord itself. Now, you can have abnormal situations where you have remnants of notochordal tissue that persists, that it was supposed to degenerate, but it doesn't. And we call those chordomas. So they can be benign or malignant, and a third of them actually occur specifically at the base of the cranium, and they oftentimes can extend all the way to the nasopharynx, and that's what we're looking at here. In this medical image, you can see where the brainstem is. This is an axial or transverse cross-section through the brain, through the head, and you can see the cerebrum here, the very, very top of the cerebellum. Here's the brainstem. Here are the orbits. This is the nasal cavity, and this is the tumor or the chordoma located here. They do grow very, very slow, which I think is definitely shows up when you're looking here that the median age for diagnosis of these tumors is 49 for the skull and 69 years for the spine. So they must grow really, really slow considering these remnants were there at birth. Unfortunately, they respond really poorly to treatment, and they oftentimes metastasize to other structures. So a chordoma is just something that you need to be aware of, and I wanted to sort of highlight this clinical application because it is an important one. Okay, now the rest of the vertebral column is going to develop from surrounding mesenchyme that you're going to get some chondrification centers that appear. And you actually get 2 chondrification centers, and these centers are supposed to come together, and then you end up having 2 ossification sites, and they're going to get the vertebral arch. And I talk about failure of this vertebral arch to close or fuse when I talk about my lecture on neurulation, because we talk about neural tube defects, and the development of this vertebral arch is actually stimulated by the underlying neural tube, and it's very, pretty common as far as defects are concerned. So if you need to see the different levels of spina bifida, that's going to be in the neurulation video. But there are other conditions. The Klippel-Feil syndrome is a syndrome where you actually can have cervical vertebra that will fuse together where they're not supposed to be fused together, or you can have reduced number of cervical vertebra bodies. And this can cause a lot of pain. The nerve root number may be reduced, or it could be normal, but the intervertebral foramina are really small and the nerve roots are small. And oftentimes these individuals have a lot of pain. We're going to talk about them, about this syndrome when we do the flipped classroom session, and then you're going to get to meet some patients who have this and see that it can be a very painful condition, and it might not be diagnosed for a really long time. And so there are other sort of things that go along with this syndrome, but they're kind of sort of nondescript. Like a person might have this condition and not know it for a really long time. And it also goes along with some scoliosis and some urinary tract infections. And another condition you need to be aware of is called a hemivertebra, and this is where 1/2 of the vertebra fails to form. Usually it's a chondrification center that just fails to develop, or there's a failure of fusion between the 2. Usually you have 2 that come together, but you just might not have 1, or they don't fuse. And this is the most common cause of scoliosis, or at least a congenital scoliosis. Scoliosis is where you get a lateral curvature, and there's oftentimes a rotational curvature of the spine. And so this is the most common cause of congenital scoliosis. And then another thing that can happen is you might get an accessory rib. So the costal processes are supposed to develop in the thoracic region, but sometimes they develop in the cervical or the lumbar region. It's most common to have these accessory ribs develop in the lumbar region, but it's more clinically significant to have them develop in the cervical region because they can put pressure and disturb and disrupt the brachial plexus or vascular structures in the cervical region. So you have this thoracic area here, this inlet here that has a lot of neurovascular structures that course in this area. Then when you get to that area in gross, you'll understand why. It's kind of a small space and a lot of things going through there. And you can get compression if you have an accessory rib. So these are a few radiographs that are showing accessory ribs. There are lots and lots of them on the internet if you wanted to look at some other ones. So clinically relevant for cervical region, but most commonly found in the lumbar region. Okay, I hope that you enjoyed this short ride on the development of the vertebral column, and I will see you in class. If you have any questions, just send me an email or find me on campus. Thank you.